Now, can we use CT at the time of closure itself? This was a patient of mine that lived a couple hundred miles away from my hospital. He couldn't come for procedural planning. And this is what I saw on my TE. You can see that this is a whale tail. This is like looking at the tail of a whale, splitting in half. This is looking from the left atrial appendage, from the left atrium into the left atrial appendage, our transeptal puncture. And you can see here like multiplanar reconstructions done on FAST. These are the view, the actual TE by planes. And basically, we had to abort this case because it was hostile in all sense. We sent that information to the vendors, and the vendors told us that no, it is impossible. It is not closable. But we went ahead and got a TE. A CT, and this is how his appendage is looking. So far from a real whale tail anatomy, you can see this is the so-called seahorse morphology in which you have, this will remind you like a seahorse here if you look at it. So basically you can measure the height at different points, etc. We sent this to the vendors, and they again told us that this is a hostile anatomy. But because of this CT, we actually came up with an idea of doing a sandwich technique of a double seal device. And this is the first time the sandwich technique was tried for such hostile anatomy with successful closure and no peri-device leak. This is something that we presented at ASC in the Interventional Echocardiography Conference. But you can take it a step further, and this is something I've done for challenging cases. And on my echo machine, I merge the CT with the live echo, and it allows better orientation. It allows optimization of angles as we had planned them. And it also helps you in cases that you need further guidance because of complex anatomy. Now, what about post-LAA imaging? So far, the IFU recommended 45 to 2 months and then at 12 months, but TEs are invasive. TEs may produce inadequate sampling. It depends on acoustic shadowing and acoustic windows, and pre-endothelialization may mask Doppler leaks. And this was very nicely proven in the dog model for the plug device that was sent to the FDA for their initial approvals. So we have gone completely away from TE to doing CT. And the big things that you want to look into is like for peri-device leak or for device-related thrombus. So I would recommend this paper by Nesselberger from 2022, very informative. And this paper by Kramer and another one by Korshom. So basically one goes into the plug device and one goes into the double seal device, and it allows you to grade the hypoattenuation thickening. And it gives you an idea of what's pathologic, high risk, and what you should be more aggressive than not. So this is an example of a double seal device in which the left atrial appendage has been completely and successfully excluded. And that's something I used that verbiage in my report, successful exclusion of the left atrial appendage with this device. And that leaves to no questions whatsoever. But what's the threshold that we use? If you have distal to the device anything in the 3-digit Hounsfield unit, that is thought to have contrast in it. So anything above 100 has contrast in it. I did this simple just for representation, but of course you need to look in multiple planes, etc. And this is another device that has been in which the appendage has been successfully excluded. There may be a little bit of hat there, but just below the cove of this plug device. So this is like of no concern. One of the reasons why I feel that, at least in our lab, has been of tremendous values to get more than just a couple of systolic phases, is that we actually can show, and this is a case in which one of the reps had told us that there's no contrast, and they felt comfortable, but you can actually see the dynamics throughout the cardiac cycle, and you can actually prove that there's some flow going back. And this was a case of a small peri-device leak. And this patient came with another indication for a TE, which I did. And you can see how sometimes these are very subtle. You have to know what you're doing with the Nyquist limit. And more importantly, when you're reading this, remember that the vena contracta of these leaks is measured from the device and away to the surface and not as an arc. I do still report the arc of the circumference. I feel it's important to know it, and it's a very simple measurement that you can do on Terra with the angle measurement to the center of the device. But this patient did very well after this. This is another patient of ours in which you see that this lobe, and unfortunately patients, the left atrial appendage are not made for devices, but this is a patient that had a lobe that was not completely excluded, and you have to be forthcoming, and this is a patent left atrial appendage. The question becomes what the vena contracta is, if you feel comfortable that the risk for thromboembolization has been mitigated with respect of the risk of bleeding, and that's a joint decision with the patient, and that is something that if greater than 5, there may be an indication for closure or not. Now, there are cases in which you get actual thrombus, and look at this, the left atrial appendage. This is a double seal device. You can see it is pedunculated, it's sticking into the left atrium, and this is a very high risk case because this can embolize. But if you're careful enough, and this has not, I have not come across with other case like this, and I think this is where CT really outshines anything else. Look what's going on in the left superior pulmonary vein there. Exactly, that's thrombus. So the next round of, after some time, we had to do a TE for this patient, and this is my TE. And just to prove how easily you can miss this, unless you really know how to play with the biology of your machine when you're doing these reconstructions and you know how to optimize your image, this may look okay to you, and you may be missing that there's potentially a lot of thickening. And unless you know when to go for the left superior vein and whatnot, this may easily be missed as well.